why don't we start? Did we lost Vinie? Yeah. So there are a couple of questions to Vinie, but there's one from Anna. And how easy was the tool to be administered by lay cadres? As you know, nurses are overwhelmed. Anna, can you please comment?
Sure, thanks, Jorge, and thank you for the question. I think it's a really important one. I think in considering any screening tool, our first sort of batch of questions is about whether the screening tool works and effectively identifies children who need to be tested for HIV. But then that second batch of questions is about the operational feasibility and whether this is a realistic tool to implement in settings where resources are very constrained and where healthcare worker time is in high demand. So we were very sensitive to this in the development of our screening tool. So the first thing we did is we built a tool that was suitable for a lay coder to be the one doing the screening. So the questions are non-clinical. You don't need any clinical training to be able to implement the tool. And they're also not sensitive. So I think a lot of screening tools ask pretty sensitive questions about sexual behavior or risk exposure, whereas this screening tool is just based on testing history. So that means you can be implementing this tool in a public area like a waiting room. And usually you could do it very discreetly just by looking at the patient card. So you could even do the full screening without even taking a verbal report, just looking at the testing history. And we took a couple other operational steps, such as developing the tool both in English and in the local language, which in Malawi is Chichewa. So that really opened up the ability for other lay coders to be the ones implementing the tool. And we saw really high acceptance of the tool by the healthcare workers. We ran a series of focus group discussions. So we really got to hear their perspective about how the pilot went. And they said it was very easy to implement and that it did alleviate some of the demands on healthcare worker time. And it took about 2 to 5 minutes to do the screening tool for each client. So overall, very positive feedback. So I'm happy to share more details if the question asker wants to get in touch with me via email, but otherwise I'll turn it back to you, Jorge.
Yes, thank you. And while you are there, so let me just, a question for clarification. You refer that 22% of 24% of the mothers were eligible for testing, right? And that means that the rest of them were already being tested or had HIV testing available. So you have like 80% of the mothers that already have HIV tests available on your population?
Yeah, that's a great question and something I'm happy I get the opportunity to clarify. So even though this screening tool is looking at the mother's testing history, its only objective is to assess the risk to the child. So it's not actually an adult screening tool for mothers. It is specifically about this 2 to 12-year-old child. So the 24% of mothers who are screened in and referred for testing, it's because they have not had a test since the end of the breastfeeding period. So there could be some risk to the child who is breastfeeding. But those mothers who are screened out, that only means that they had had a test at the end of breastfeeding. So there's no risk to the child, but that doesn't necessarily mean there's no risk to the mother, because of course she could have acquired HIV in that time period that the child was done breastfeeding, but still in this age group. So we recommend that the mothers who are screened out are still assessed for HIV risk so that they can be properly referred into testing if they need it. But this screening tool assesses specifically for whether the child needs to be referred.
Very good. And one last question from Rhoderick to Anna. how well the two perform in terms of sensitivity and specificity. Is that what you mean, right, Rhoderick? Anna, please.
Yeah, another great question. So we conducted this pilot as primarily implementation research. So we ran the pilot, and children between 2 and 12 years old at the facilities were screened in, but only those who were screened in and accepted testing actually were tested and had their test result captured. So for the full gold standard screening tool evaluation, we would need to test the children who were also screened out, and that would allow us to see how many children who were actually HIV positive we had missed with the screening tool, and give us those markers like sensitivity and specificity and negative and positive predictive value. And that is a really important phase of assessing a screening tool, and something we're hoping to move into next year. But for this pilot, it was just the implementation research to really see if it was operationally feasible and get some first impressions. So we don't have those indicators yet, but we hope to next year.
All right, thank you very much, Anna. A question for Rhoderick. Can you comment on the barriers, if any, to test mothers at the time of application of the screening tool? Because it seems to me that this is one of the critical points of your screening. Are there any barriers to test the mothers at the time when you apply the screening tool?
Certainly, there are a couple of barriers because, as we know, not all the time is the mother available to be able to test the mother. So sometimes the children are brought to the health facilities by a relative. The mother might be working somewhere else. So it's those are the kind of barriers of having the mother status at the time of screening. So yeah.
Okay. Yeah, I think that's that it has a major impact on your specificity, right? On your tool when you do not have the HIV status of the mothers, right?
So that's the where the tool is important, because it doesn't rely on the maternal status alone. And we know that the current system is, if the mother status is known to be positive, then the child is automatically eligible for testing.
Okay.
What the tool does is to use these extra screening questions. So it's, you test the child either if the mother is HIV positive, or they are presenting with any of this set of other markers or rather symptoms.
Okay. Thank you so much, Rhoderick. There's a question from Vinie, from Linda Stranix Chibanda, and actually there are two questions from her. One is, what could be done to further reduce the point of care viral load result turnaround time to be able to deliver results much closer to the date when the sample was collected? And the second, do you have any insights about the barriers to switching ART regimen in those who remain unsuppressed despite adherence counseling?
Thank you very much for the question. I think I will start by the first one. Right now, at Chidamoyo now, we have, I think, only one lab scientist. I think to improve this one, maybe the government should think of increasing manpower at the rural side, because we don't have a lot of lab scientists. So right now, there's only one who's in care of all these viral testing. And then maybe increasing also point of care, because right now at the Chidamoyo, we have like 3 to 4 Samba machine. But I think the main problem is the manpower. we need to increase the number of lab scientists and the number of research scientists at the clinic. And the second question, please, can you repeat? I didn't.
Of course. Just give me a minute. Yes. Do you have any insights about the barriers to switching ART regimen in those who remain unsuppressed?
Thank you. Yeah, I think with the problem with adolescent children, adolescent and young adult at Chidamoyo is that as per the guideline, usually the clinician want to emphasize on adherence. And some of the children were on PI-based line regimen, and then after emphasizing on the adherence, usually to switch from a second line to third line, a genotyping resistant testing is required, and then sometimes it takes time, so it's not really feasible for clinicians to switch rapidly. So I think maybe this is one of the reasons why we can see the rate of switching is being low or decreased in our study.
Okay, let me see the chat box. Megan, you have shown us that there's a enormous ground to improvement on the testing. And I wonder whether you could comment on how do you go about that in terms of what are your recommendations once you have identified this major challenge on millions of women that go untested.
Sure, definitely. Thank you, Jorge, for the question. I think it's first and foremost important, going back to what Rhoderick had said before, just to remember that that these women and these children kind of already meet the requirement to be tested. I think there's sometimes some confusion and some hesitation in testing and the fear of over-testing pediatrics given the lower yield than adults. And so it's just important to remember first and foremost that that any biological children, and this is the PEPFAR's COP guidance for this year, that any biological children of a person on ART, biological children or sibling up to age 19 should be tested. And so that kind of takes away any of that confusion or, do we screen, do we not screen? And I think my colleagues did a wonderful job presenting really great data and information on that. But in this case, it's just important to note first and foremost that, those children meet that criteria to be tested and should be prioritized to be tested. And then I think that's the second thing that is really critical that programs look into really maximizing and emphasizing and strategizing on is the coordination with our community partners and with our community organizations to be able to help facilitate index testing and reduce that gap that we currently see. Again, the analysis that we did is a very kind of broad overview of it, and we know that there are some limitations in the analysis we did, but I think it shows the opportunity to really educate and collaborate with our community partners to be able to facilitate testing and being able to refer families, refer children, biological children and siblings to be able to receive those services, and if identified positive, have quick linkage to ART, and again, that other psychosocial support. I know at the Office of HIV here at USAID, we're really focusing on the collaboration with our orphans and vulnerable children programs, which I assume a lot of people on the call as well have some experience with, and that's just an example of the ability to really collaborate together and join forces to be able to bridge the gaps and make sure that time the families in the communities are well connected to the health facilities and receive those wraparound and comprehensive services.
Thank you so much. Very, very fast speed for a complex response, right? Thank you, Megan. So I've been told that we have a few extra minutes. So there's one question to Rhoderick. I'll read it out here, Rhoderick, in case you don't. Do you see the chat box?
I would have to scroll if you have it right in front of you.
I'll read it for you. Yeah. Sorry that I missed your presentation due to technical issues, as many of us have. But the question is, you mentioned the predictive positive value and negative value, which are affected by prevalence. Nevirapine decrease, negative NPV decrease with increasing prevalence. Any comments on the HIV prevalence in the Ugandan sites? So I think the question is about the impact of the HIV prevalence on the negative and positive predictive values.
Yes, thank you for the question. Indeed, positive predictive value and negative predictive value are influenced by prevalence in the population you are looking at. And in Uganda, prevalence in the sample that we looked at, there was an HIV positivity rate of around between 1% in the sort of the developmental sample, the sample we used to develop the tool, and around 1.6% in the sample that we used to validate our tool. But of course, the measures we are trying to use to determine how useful our tool is mainly sensitivity and specificity. You know, to evaluate our tool. So we don't rely that much on the negative predictive value because of the fact that it depends on prevalence. But it is low prevalence indeed.
Okay. I think we have addressed everything on the chat box, and we still have 1 or 2 minutes open the floor for any additional comments. I haven't heard from Agnes, but I don't know if she's on. But any comments, Agnes?
I'm on, but my camera is not working.
Okay, so since we were the only one that we didn't have the chance to hear, so maybe you can do you have any additional comments on the session, please?
Maybe just to say that the study that we did in Kenya, just looking at the infected infants, actually just ties with what Mary Hayes presented in the first slide, and where she talked about the main things were no ARTs for the mother, and that is what we found, and issues about preventing new infections in mothers. In our study, we found that mothers were not being tested on time. So that issue about retesting for mothers, both in ANC and PNC postnatal, needs to be emphasized. Yeah, thank you.
Okay, well, thank you. We are right on time. And thank you for all the panelists for this wonderful discussion. And I believe that at last we are able to circumvent the technical limitations. And I wish you all and all the audience a great 2 days of discussion.